Okay, welcome everybody to our education session on axial spondyloarthritis. My name is Professor Hasan Tahir. I am a consultant rheumatologist. I'd like to introduce you to my colleague, Sean Bamford.
Hi, I'm Sean Bamford. I'm an advanced practice physiotherapist working in rheumatology, and I work alongside Professor Tahir in the axial spondyloarthritis service. So no doubt I would have met some of you.
And we also have Nahid. So Nahid, would you like to introduce yourself?
Sure thing. My name is Nahid. I'm a highly specialist MSK physiotherapist. I work quite closely alongside Dr. Tahir and Shan as part of this service.
Thank you, everybody. So thank you for joining us. What I'd like to do is, the purpose of this session is to go through or give you an understanding of axial spondyloarthritis. Most of you have been recently diagnosed with this condition, and the aim is to introduce you to the condition and give you some sort of advice about what can be done and what sort of treatments are available as well. So I'll do my little bit in the beginning, and then I think Sean will talk a bit about her aspect of the condition, and we'll leave you then with Nahid to talk about the physiotherapy aspect as well. So the next slide, if I can get that going, is the question is, what is axial spondyloarthritis? This is a new terminology. A lot of you may have heard of the word ankylosing spondylitis, and this terminology has changed over the last few years. And as we said, we call it axial spondyloarthritis. The word axial basically means the spine area, and it's an arthritis, usually an inflammatory type of arthritis that affects the spine. Most of you, yourself who have this condition will have back pain as the predominant symptom. Back pain being really common. And by the way, the difference between this type of back pain and the type of back pain one gets in mechanical pain is that this type of pain, i.e. that you get an inflammatory pain, is usually stiffness. It's usually when you're resting, it's worse, and with movements it gets better. And we'll talk a bit more about that in the slides going forward. Classically, we tend to find this condition in those under the age of 45, that when the symptoms begin, and undoubtedly you can get it when you're older than 45, but the symptoms tend to begin before that. Symptoms vary. There'll be times that the symptoms will come on and then they'll stop and then restart again, and others, they are persistent and they carry on. And so they sort of vary. So you may have good times, bad times, flares, and so forth with this particular condition. We don't know what causes it. So like most of the inflammatory arthritis, we just don't know what causes it. Possible genetic link, and a number of you would have heard us say, well, we need to do blood tests. We want to do something called the HLA-B27, and there has been some sort of linkage with that particular haplotype. So those who potentially have this haplotype or gene, something may go on and switch this particular gene and then cause the condition. However, you can get this condition, you can get axial spondyloarthritis even though you don't have the gene, or should I say the haplotype. What we know is that patients who have other conditions are more likely to get more likely to get pain in the back, which is inflammatory, and hence the spondyloarthritis. And these include patients who have psoriasis, so those who have inflammation of the eye, those who have inflammation of the gut called colitis, or Crohn's disease. So we are seeing more and more patients who've got Crohn's disease who've gone undiagnosed with back pain because they've not really associated it. Those in the eye clinic, those in the skin clinic who've had these undiagnosed back pains for many, many years. And because of awareness, we're seeing a lot more patients with this. So basically, what is the cause of my back pain? I sort of touched on this a bit earlier on. And as I said, I just think it's in a very, very, very simplistic way to look at it. It's inflammation. And classically, this is inflammation where your ligaments and tendons attached to the spine. So a ligament is like a band that connects one bone to another bone, and a tendon is where a muscle attached to a bone, and that attachment point can get inflamed. And this inflammation that you get can, if you allow it to continue, result in this extra bone growth, which ultimately can sort of stick together and fuse. And that's sort of what causes a lot of the joint stiffness that a number of you may experience. And ideally, what we want to do is we want to nip it in the bud and capture people quite early when they have this inflammation, so they don't ideally get this new bone formation and worst case scenario fusion. Is what we're trying to avoid doing. How is my condition diagnosed? I've been told I've got to do this slide as well. So it's you'll find that a diagnosis of axial spondyloarthritis is not about an X-ray or a blood test. It's actually about making a judgment call, and that judgment is based on a story. So we will take a story from yourselves, so taking your history. We'll find that the history, oh, that sounds very suggestive of an inflammatory sounding problem. You may have psoriasis, you may have had, say, inflammation of the eye. So we have a high clinical suspicion on a story. Then what we'd recommend is we'll do an X-ray. And an X-ray doesn't prove or disprove that you have the arthritis. The X-ray will just, or the MRI or the X-ray will say, there's an abnormality there, which you can get with other conditions, but that abnormality with the story that we've gleaned may be suggestive of an inflammatory problem. And likewise with bloods. That's why I say that just because we say patients can be HLA-B27 positive or inflammation markers, that helps us. But you actually have patients who are HLA-B27 negative and inflammation markers negative and still have the condition. That's because we as clinicians make a judgment call based on the story, the blood tests, the images when we make that diagnosis. We get it wrong at times. We do diagnose patients with the condition, and then over time we start treatment. We realize, well, are we clear that this is definitely the diagnosis? And very rarely we do change it. And likewise, we may get it wrong as well. We make the judgment that you may not have an inflammatory back pathology, and then time evolves and we think, well, actually, no, I'm going to change my opinion because certain things have changed, and then we label you. As I say, it is a judgment call ultimately. I'm going to hand you over to Sean to talk about the next slides.